Ya estamos. Hi, Elina Kari.
Hi, can you hear me?
Yes.
Yes. Hi, Elina. How are you?
Welcome.
Hi, good, thank you. Hi, let me start. We all have our virtual backgrounds. I look a little funny with the digitization.
No, it's fine.
Let me just, I have my talk. I just want to see if I can share the screen. This is
Yeah,
where
sure.
I get a little bit Zoom funny.
I was saying to Monica that in your CV, I saw that you speak Spanish, that you went to
don't do
Peru.
So,
I was so happy, like you spoke Spanish. I was like, all the participants can talk to you in Spanish, but it's a joke. Don't worry.
No, todo está
Whomever.
bien. Yo creo que sería mejor si yo doy la palestra en inglés, pero
En inglés,
si hay
yes.
unas preguntas, puede preguntarme en español.
Ah, mira, ya ves, súper bien. Great. Perfecto.
Let me just see if I can. Vamos a ver si la tela que yo tengo, ustedes pueden ver.
Sí, ya está para. Ajá.
Fondo virtual.
Okay, let me do that. Okay.
Y ya los participantes. A ver, vamos a...
¿Pueden ver todo que tengo aquí?
Sí.
Sí.
Okay.
Te dije que hablaba muy bien español. Como fue a Perú, fuiste a Perú, ¿verdad? You went to Peru.
Sí. Fui en, wow, más que 20 años atrás.
No, muy bien.
Pero yo ayudé con un estudio sobre malaria antes que yo entré en la escuela de medicina. Entonces, fue 6 meses en la selva que yo necesitaba hablar español.
Sí, no, definitivamente. Y también hizo Latin American Studies, vi por ahí también.
Sí.
No, estudié el CBU, sí, lo estudié bastante bien.
Bueno, creo que la mayoría de las palabras que tenemos en medicina son bien parecidos inglés y español porque son todos latinos. Entonces, pero bueno, yo hablo una versión de español médico que es más para los pacientes. Entonces, cuando intentan hablar, bueno, gracias. Entiendo que ustedes quieren esperar un poquito más hasta que más personas lleguen.
Sí.
Sí. Sí, unos 6 minutos en lo que son la hora exacta para... Todavía faltan 6 minutos. No, sí, okay. 6 minutos, ¿no? Sí.
Ok. Entonces yo voy a recogerme un poquito de agua y ya vengo, ¿ok?
Sí, adelante.
Ok.
Ya ves, te sorprendió, Mónica, ¿a poco no?
Sí. Muy buen acento y todo.
Sí, no, bárbaro, o sea que... Entonces, mira, lo que vamos a hacer es, voy a presentarlos y ella pues va a empezar su plática también y ya al final ya, no sé si tengas el de YouTube ahí, a veces no vienen. Sí.
Pero no te veo en los videos.
Generalmente tiene tarda como unos 20 segundos, algo así, tiene
ya está. Ya, sí,
y y nada más, sí ponlo si lo tienes en tu computadora, ponlo en silencio, porque si no empieza a hacer eco.
Ya está en silencio.
Sí, ajá. Y ahí mismo le puedes escribir tú en el chat en vivo, a ver si puedes poner ahí que pongan sus preguntas y no sé cuántas personas tengamos el día de hoy, pero igual las que estén en YouTube, pues si hacen alguna pregunta, pues ahí te lo agradecería mucho.
¿Nos pones de anfitriones, Erika, por favor?
Sí, claro. También Mónica está. Voy a poner también a Elina Kari.
Okay.
Bueno. Ok. Ya están ustedes. Ya está YouTube funcionando y nada más faltaría grabarlo en cuanto empiece. Sí, es que yo creo que practicar la medicina en Estados Unidos tienes que saber español, definitivamente.
No, la población latinoamericana cada vez es mayor y cada vez menos hablan inglés.
Sí, le estaba diciendo a Elina perdón, adelante.
No, Elina, ¿qué porcentaje de pacientes hablan solo español en tu consulta?
Con mi consulta, porque todas las personas saben que yo hablo español, casi una mitad.
Ok.
Lo que te dije, muchísimo.
Sí,
Yo
porque
fui...
yo también estoy en San Diego y también en Los Ángeles, fue lo mismo.
Sí. Yo fui a la clínica Haas cuando estaba Alex Bien, es que no sé cómo se pronuncia en inglés, y You're Sick.
Oh, Bean, yes, Alex, Joe Ersick. Joe Ersick
yes.
un colega muy, ¿cómo se dice? Íntimo. Él es bien grande amigo de mi esposo.
Mira.
Y nosotros hicimos lo mismo fellowship en el House Clinic. Entonces conoció a él.
Sí, estuve yo cuando estaban ellos dos.
Ay, qué bueno.
Sí, estuve ahí un mes nada más.
No,
Son muy agradables todos ahí.
Joe es una persona muy buena.
Y también me tocó cuando estaba el doctor de la Cruz, todavía el doctor de la Cruz, de hecho yo fui con él.
Sí. Bueno, no, él se murió bien rapidito, muy rápido.
Sí.
Fue horrible cuando él se murió.
Sí, que fue hace, ya hace bastante, ya hace como, no creo, unos 10 años, 8 años, no sé, algo así.
Yo empecé mi fellowship algunos años después que eso, en 2011.
Y había también un mexicano, ¿no? Yo me acuerdo que era muy brillante este mexicano, porque el doctor de la Cruz era muy bueno y me dijo, ándale, vamos a ver quién quiere entrar a la clínica House. Y es un currículum de gente que quiere entrar cuando hacen la entrevista. Y entró un mexicano, pero ahorita no me acuerdo de su nombre. Un mexicano ahí a hacer el fellowship. ¿No te acuerdas?
Oh, God.
No
ahora está en Harvard, ¿no? Creo que está en Harvard.
No me acuerdo muy bien, pero era brillante. Yo me acuerdo que vi su presentación, qué cosa más increíble. O sea, están todas las mejores universidades y pues todos son brillantes.
Bueno, todos no.
Los escogen también por la entrevista, ¿no? Y todo esto. Me acuerdo que me decían que...
No, pero sí, no, tenía razón, porque con nuestra especialidad de otología, neurotología, solamente tenemos algunas 16 vagas por año para entrar en hacer el entrenamiento.
16 de neurotología.
Solamente algunas vagas cada año, entonces solo las personas que están participantes, ellos pueden escoger los mejores, porque solamente hay algunas vagas y siempre hay más personas que quieren entrar. Sí. Pero es una especialidad bien chica, muy especializada.
Sí.
Para una parte de la cabeza tan chiquito.
Sí, me tocó ver las entrevistas ahí en la clínica House, qué impresionante toda la gente que llega, todo lo que presentan, que presentan sus investigaciones, porque hacen investigaciones para poder entrar ahí. Sí, no, la verdad es que está increíble ahí. Pues ya son en punto. ¿Quieren que empecemos en punto, doctor García, la doctora Mónica? ¿O nos esperamos?
Esperamos.
No, la doctora tiene un compromiso, ¿verdad, doctora?
Bueno, a las 7:30 y tiene una niña arriba que creo que va, pero podemos esperar un poquito más si quieren.
5 minutos nada más, si nos permites, Elina.
No entiendo. Mi mamá es de Brasil y entiendo que casi nada empiece a la hora en Brasil.
Se tardan en entrar, la verdad, es cierto.
Sí.
Ahorita generalmente nosotros manejamos, a veces se nos llena el Zoom porque tenemos una capacidad de 100 y por eso manejamos también YouTube. Entonces, ahorita estamos live en YouTube. No sé si hay algún problema, Elina, con que estemos en YouTube.
No es ningún problema.
Oye, Elina, antes de que empiece el Zoom, ¿ustedes hacen algún screening de manera rutinaria para citomegalovirus?
Diga más una vez porque había una pausa.
So for cochlear implantation, do you routinely do a screening for CMV?
Or for CMV or?
Sí, citomegalovirus.
El problema con esto es que la mayoría de los niños que están entrando en el proceso para un implante coclear, ya salieron del hospital, ya tienen más que 4 o 5 meses. Y el problema con el examen, la prueba que tenemos para el CMV, es que necesitas sacar antes que salgan del hospital después del parto. Porque después que salen, se pueden infectar o tener alguna, ¿cómo se dice? Pueden ser expuestos. Entonces no sabemos si fue congenital o fue después que nació. Ahora estamos empezando en pensar aquí en los Estados Unidos que necesitamos hacer esta prueba antes que salgan, porque ahora tenemos esta prueba para todos los bebés de newborn hearing screen, que tienen una, ¿cómo se dice? Una ABR, respuesta de, no sé la palabra para ABR, pero tienen un examen de audición antes que salen del hospital. Sí.
Ok, porque estaba viendo que en Toronto ya lo están haciendo de manera rutinaria.
¿Cómo?
En Toronto ya lo están haciendo de manera rutinaria. El screening for
no,
CMV.
aquí, bueno, Canadá está más avanzada que nosotros en muchos aspectos. Pero no, aquí en los Estados Unidos no estamos haciendo. Y el otro problema es que todos los estados son diferentes. Entonces, todos los estados ahora hacen la prueba de audición antes que los niños salen del hospital, pero no fue, ¿cómo se dice? Uniforme. Entonces, todavía hay diferencias entre los estados.
Ok. ¿Cómo vamos? En YouTube tenemos 2 nada más. Y acá 44.
¿Vamos a empezar entonces?
Sí, déjenme nada más presentarlos. Un pequeño protocolo y la presento brevemente. Bueno, pues buenas tardes. Bienvenidos al Colegio Mexicano de Odontología, Neurotología y Cirugía de Base de Cráneo. Hoy me da mucho gusto presentar a nuestros panelistas, que son el doctor García Lara León Felipe, que es jefe del Departamento de Otorrinolaringología de Pemex Picacho y expresidente del SMOL. También a la doctora Mónica Rodríguez Valero, que gracias a ella tenemos en la ponte el día de hoy. Te agradecemos muchísimo. Ella hizo un fellowship en Inglaterra en neurotología y ahorita está en el Centro Médico ABC. Y si me permite, voy a hacer una pequeña reseña de nuestra ponente del día de hoy, que es Elina Kari, con el tema malformaciones del oído interno, implante coclear, la cual, bueno, tiene un currículum impresionante, doctora, pero voy a decir algo más resumido, si me permiten. La doctora hizo su escuela de medicina en la Universidad de Michigan y hizo otorrinolaringología en Emory University. Después hizo su fellowship en la House Ear Clinic. Ella actualmente es profesor de la Universidad de California de San Diego y tiene residentes a su cargo y tiene también fellows a su cargo. Ella es también directora del curso de hueso temporal de la Universidad de California desde el 2018. Pertenece a muchas sociedades, entre ellas tenemos la American Neurotology Society, American Academy of Otolaryngology and Neck Surgery. Ella es coeditora de la Audiology and Neurotology y tiene diversas publicaciones, tanto en revistas como en libros, hablando precisamente del tema de hoy, que es malformaciones cocleares, genes asociados a hipoacusia e implantes de tallo. Doctora, bienvenida. Muchas gracias. La doctora habla español. La presentación va a ser en inglés. No, la presentación será en inglés y después las preguntas pueden ser en español y cualquier duda, pues estamos para servirles los tres que estamos aquí con ustedes. Adelante, doctora.
Muchísimas gracias. Thank you very much. Again, we'll do the talk in English. I do talk kind of fast, muy rápida. So if you need me to slow down, please either, I don't know how you do this in Zoom, you can raise your hand or just, you can actually ask me a question to slow down.
Sí, puede levantar la mano.
Okay. So I wanted to go over a little bit of embryogenesis because a lot of the implications from cochlear malformations really have their origin in the embryogenesis in the first trimester, We'll then go through some of the medical considerations that will probably be no different in Mexico and probably very familiar to all of you. We'll briefly talk about the role of imaging, and then go through a lot of the more common cochlear vestibular malformations that we see, and some of the more uncommon ones too. Then we'll talk about a little bit about why you would choose one company or electrode over another when you're trying to implant a patient with cochlear vestibular malformations. I'll spend a little bit of time talking about the evolution of cochlear implant candidacy and where we see the future going in some patients. So as you all know, a cochlear implant has two parts. We have the speech processor and the microphone with the coil with the magnet that is shown on a different view here, where it connects with the internal receiver, which is completely buried under the scalp. Then you have the electrode array, which is inserted through the mastoid after a cortical mastoidectomy is performed. There's another small window that you make called the facial recess, so you can access the cochlea. And then either through the round window or through a cochleostomy that you create surgically, you insert the electrode inside the cochlea, which is then meant to directly stimulate the nerve endings of the cochlear nerve or the hearing nerve. You need both parts of them to work. Some patients sometimes have this thought that, oh, does this mean I can have it completely implanted? No, you obviously have to have an external part. I did want to mention briefly auditory brainstem implants, because for some patients where the malformation is so severe, such as having no cochlea at all, or when there's absolutely no eighth cranial nerve, this would be an indication for an auditory brainstem implant. These were originally developed for patients with neurofibromatosis type 2, or those individuals that have bilateral vestibular schwannomas or acoustic neuromas, where they can't have a cochlear implant because there is not a functional auditory nerve, or that nerve has been resected from prior surgery. The outcomes with auditory brainstem implants in those individuals are really not very robust, but they do significantly aid with sound awareness and cued speech. But most people do not get spoken language ability with this implant. They have expanded the indication, or trying to expand the indication, for individuals that have no hearing nerve or who were born without cochlea. And there are a number of trials going on in the United States examining the language outcomes in that subset of children. This is already being done widely in Italy and in Turkey. And there's a lot of controversy about when to proceed with an ABI versus a cochlear implant versus sequential. And that's a topic that I'll touch on later. So a brief history. Work on cochlear implantation was being done outside of the US, predominantly, I believe in France, all the way back in the 1950s. Then Dr. Bill House, or William House, and his partner Jack Urban developed the first single channel cochlear implant that they used in humans. And then the multi-channel implants were then developed in the 1980s and started being used then. They became approved for use in children ages 2 and older in 1989. And that's really when we started this whole era of pediatric cochlear implants. These were the days when we really only had CT scans, and we weren't really appreciating some of the abnormalities of the cochlear vestibular nerve as much. This was also a time when we were only doing them on one side. Move forward 11 years, it was finally approved for children ages 12 months and younger. And we all know by now that the earlier you implant, even as young as 4 to 6 months, which is usually the minimum amount of time that you need just to go through all the testing and evaluation process, the earlier you do it, the better the overall spoken language outcomes are. So 6 months and 12 months make a difference when they're compared to 2 and 3 years old. Sometime between the 90s and the 2000s is when we started doing sequential, or actually even simultaneous bilateral. So simultaneous bilateral, doing both ears at the same time, really became standard of care in the US in the late 2000s and early 2010s. Now it is considered standard that if a child is born with a bilateral severe to profound hearing loss, that we proceed with both ears at the same time, because we know that the ability to achieve near normal hearing and function is best with 2 ears. We also know that they do better than when they do sequential implantation, because the brain always seems to prefer the first implanted ear. And that's true across many children. Even a gap of maybe 2 years can make a difference in perceptual differences in that patient of whether they like the second side as much or not. So this is just a brief review of embryology. The hypothesis has really started with Jackler and then later on with Senaroglu, which I know I'm pronouncing his name incorrectly because Turkish people have a way of pronouncing that is not more American or Latin based. But either way, both of those authors have had extensive experience in the characterization of pediatric cochlear vestibular malformations, largely based on CT scan. And the first one was proposed by Jackler at the House Clinic in the late 80s. Linking the kind of malformation to when the insult might have happened, assuming that there was some insult, not, maybe maybe teratogenic, maybe genetic, but the earlier the insult in embryogenesis, the more severe the malformation. So early on in the 4th week of embryogenesis, which is actually 6 weeks of what we calculate gestation, right? Because we calculate pregnancy differently than embryogenesis. So even well before most women even know they're pregnant, a common cavity would result if there's an insult in development that early. As you move forward over the subsequent 4 weeks, which is a very short period of time in the very early trimester, first trimester, we see that we have the less severe. So for example, you can have a cochlear hypoplasia because the vestibular system tends to develop earlier on than the auditory system. And so then you move on to the incomplete partition with Mondini, where you have a basal turn, but then the middle and apical turn don't develop properly. Here's another example where you have cochlear differentiation, but you might just have hypoplastic differentiation of what you have. Then they talked about the 5th week as having cochlear agenesis, where you have vestibular development, but not the cochlear. We expect normal labyrinthine development to happen by 8 weeks of gestation. Senaroglu then further differentiated the incomplete partitions. So because if you scan enough children, and again, back in the late 1980s, we didn't have a lot of data because most children weren't getting CT scans for hearing loss, and we only started doing them routinely for cochlear implants. So as we started scanning more children, we started appreciating the really rich diversity of the malformations we encounter. And even with the modern classification schemes, which Senaroglu has recently updated in the last 5 years, there are multiple malformations that have not been characterized or given names. And so the most common one that we've heard of is the Mondini, or the incomplete partition type 2, where you have a basal turn of the cochlea, but you don't have a middle and apical turn. So it's like having a little pearl that sits on top of a little coil. He then further separated out to incomplete partition type 1, where you have a distinct vestibular apparatus, which may or may not be normal, but then the cochlea just has this little cystic spear-like conformation. So no partitioning at all, but a distinct cochlea. And then you have other variations where you have the two fused and they become one big common cavity. But you also have a number of malformations where you have vestibular anomalies, which are not typically characterized or named. They might be described in the literature, but most people don't define those because they don't seem to impact what we think of the cochlea, which is what we really care about for cochlear implant surgery. I'm not really sure why we have all these crazy lines on my slide, but just ignore them. So for medical considerations, the first concern is what perioperative concerns do you have? You have to look at the whole picture of the patient and can they tolerate 1 to 2 hours of general anesthesia for one side, or 2 to 3 if you're having bilateral simultaneous. It's general anesthetic. There's typically not a lot of blood loss. There shouldn't be lots of fluid shift that could cause major cardiovascular problems. But it should really take about 1 hour, 1.5 to do one side, and then 2 to 3, maybe 3.5 to do both at the same time. If you're needing to push your surgery out for longer periods of time than that, you may want to reconsider whether you want to do both at the same time. But the goal is to be able to do that many in that period of time. For adult patients, if they're on blood thinners, obviously that's a consideration you need to weigh because you don't want to have the risk of a hematoma. Prior radiation therapy. Some of our children are either teens or young children that have been treated with chemotherapy, sometimes radiation for a malignancy, and that's why they have the hearing loss. If you have received radiation to your head, that can cause potential wound problems, possible breakdown of the soft tissue over the internal receiver, increased risk of infection. And you need to be very careful because traditionally for those patients, I was very reluctant to do implants on because of that risk. But I think if they don't have significant issues with soft tissue healing and they don't have a lot of fibrosis, I think it's still worth considering. I do want to point out that the presence of an acoustic neuroma or a vestibular schwannoma is not a contraindication to having a cochlear implant. So if there's anybody in the room that treats adults, we have patients that have been treated for an acoustic neuroma with radiation, stereotactic radiosurgery, where they've controlled the growth of that tumor. It has not grown for several years, up to 10 years sometimes, and they have horrible hearing, as you would anticipate. There are several papers, and I have several patients myself that have had a cochlear implant in that ear with the tumor that's been radiated, and they actually do very well with their performance. And so you shouldn't use that as a reason to not do the surgery. Need for serial MRI. Now that most of the implant companies, if not all of them, have MRI compatible magnets, we don't think that it's a problem to have a cochlear implant, even if you need an MRI. Now, it will make it difficult for you to see on that side of the head and the brain on that area. There are some papers out of Mayo Clinic with Matt Carlson as a senior author that do show that they're still able to follow tumors, even though there is a lot of artifact and distraction from the hardware. But again, just to point out, you can still have an implant and not have it interfere with those concerns. Ear infections, otosclerosis, having had prior meningitis, all present challenges. I would not call them contraindications because there are workarounds for all three of those situations, even when the otospongiosis is very severe. The meningitis, ossification, even if you see evidence of that on the scan or the MRI, I wouldn't use that as a reason not to do it because you can still get a full insertion and still have good performance. Vestibular issues, I put a question mark. That really falls into appropriate expectation management because you can imagine that some cochlear implants can also affect the vestibular system negatively. It's not a common effect, but it can happen. And if you have a severe episode of vertigo right after your implant surgery and you're already starting out as a kind of weak, older person with bad balance, that can be very disabling. So you want to consider that. Again, not common, but consider it. The psychiatric makeup of your patient and the psychosocial matrix of that family have to be considered. So in adult patients, if it's a patient with active paranoid delusions, it's not a good idea to put an implant in their head because it usually exacerbates their delusions that they're being monitored by the CIA or the KGB or whatever it might be, right? And then for children, you have to also look at the stability and the psychosocial milieu of their family dynamic. If that family does not understand the expectations to have after an implant, of the work that's required, of the amount of time that's needed, of the appropriate expectations of, no, this is not a normal hearing child. It's a child still with hearing loss that needs a lot of special care. If that family is not willing or able to accept that, then you really have to reconsider whether they're appropriate families for implantation. Dementia, do anybody deal with adults? Should I just focus on the children?
Mainly are adults. There are few doctors connected that deal with children.
Okay,
actually.
So it's actually important for me to mention all of this then. So yes. Dementia, we know that there is definitely a concurrence as with hearing loss declining, cognitive function also declines. It's a bit of a chicken and egg, meaning which comes first? Is it the dementia that worsens the hearing loss? Or is it the hearing loss that's worsening the dementia? And I would argue that it's likely a combination of both. And we have found that even patients with cognitive impairment, as long as they are able to participate and understand what they're going through and consent to that, it should not be a contraindication to proceed with cochlear implantation, provided that there are no significant concerns that a patient should undergo anesthesia, because sometimes a short run of anesthesia, even an hour, can decline cognitive function in some patients. But we know that the progressive social isolation from continued hearing loss exacerbates dementia and cognitive function, and we need to be aware of that. So let's talk about chronic otitis media and how that presents challenges for cochlear implantation. The easiest one is you have recurring otitis media or chronic mucoid otitis media. Someone has tubes placed either as a child that needs a cochlear implant, or you have the situation in which you have an adult that has a tube in place for the same reason. As long as that ear is not actively infected and they don't have current otorrhea, having a tube in place is not a contraindication to a cochlear implant, because as we all know, the tube often just falls out on its own and then leaves an intact tympanic membrane. A tympanic membrane perforation And a draining ear is a different story, because obviously you don't want a communication from the ear canal in the outside world into the middle ear space where there's an electrode going into the cochlea. In those situations, you can either stage the surgery, meaning completely reconstruct the eardrum, stage the surgery by several months to make sure that the ear is dry, there are no infection issues, and then go back and do the cochlear implant. But if it's a chronically draining ear, then sometimes you really want to also consider doing a mastoidectomy to get them completely infection-free. The challenge is that these patients often have contracted mastoids and they have very narrow facial recesses. And in order to safely and comfortably visualize everything you need to do during a cochlear implant, you really need at least 2 millimeters of space between the facial nerve and the ear canal wall to be able to fully see your cochlea and get access to the round window. With these chronic otitis patients, you often don't have that kind of a recess, and you're really limited through that tiny space. In those situations, we actually consider doing something called a subtotal petrosectomy, an ear canal closure, which is illustrated here on the right. So in this situation, you would actually close off the meatus at the ear canal and completely eradicate all the canal wall skin, take the tympanic membrane out, do a canalplasty to ensure that you've gotten all the canal skin out, everted the skin edges through the meatus of the ear to make sure it's completely closed and not trapping epithelium, and then just do a canal wall down mastoidectomy. And that way there is no worry whether you have a narrow space because the whole ear is completely exposed. And that situation has been very successful for my chronic otitis patients that needed a cochlear implant or had surgically challenges in other ways. There are patients who have canal wall down mastoidectomies on both sides and have really reached the limit of what a hearing aid or even an osseointegrated system can do for them. In those situations, you would close off their ear. And in some cases with the really wide meatoplasties, you can't just close off the ear canal because it's too wide of a space for skin to actually be able to fill that gap and not have soft tissue underneath it. So in those situations, I've worked with a plastic surgeon or a head and neck reconstruction surgeon where they can do a rotational temporalis flap and create additional soft tissue coverage. So I can then close off the ear canal, completely de-epithelialize the canal wall down cavity, completely remove all the skin, and then access the cochlea that way. And then you tunnel it under the subcariosal pocket, usually again with the assistance of your plastic and reconstructive surgeon to ensure that you have appropriate soft tissue coverage. And so all of these things are workarounds. You can get around them. Another thing that happens with a lot of children, but also adults, is that people who have congenitally narrow ear canals, and they often have an aberrant course, an abnormal course of their facial nerve. Those are very anxiety provoking because your facial nerve is not in its predictable location. Sometimes the space between your nerve and your ear canal is also very narrow, and you don't want to obviously cause a facial paralysis. So in those situations, if you cannot get proper access through a facial recess in the traditional fashion, I've also closed off the ear canal and taken the canal wall down just to be able to safely access the cochlea. Because again, if you're dealing with a deaf patient, they don't need an eardrum. They also don't need an ear canal. And visibly, cosmetically, you don't notice a difference. Only if someone really opens up the ear opening can they see that it doesn't have an ear canal. These patients will definitely need to have continued monitoring because there's always a risk of a iatrogenic canal cholesteatoma by retained epithelium inside the ear canal. And so you need to follow them with clinical exams, maybe consider imaging, although a CT scan is usually not going to be very beneficial because it's just going to show opacification. But either way, you can get serial imaging to see if there's been progressive change. But this has been very successful for a lot of people who presented very challenging ears, in addition to deafness that needed to be treated with the cochlear implant. Does anyone have any questions about that? I spent quite a bit of time talking about a lot of scenarios.
I don't know, Dr. Monica?
When you do a blind sac closure, do you do it in the same surgical time or do you do it in different times?
It depends. So there are some cases, for example, in charge children. I don't know if you've ever dealt with a charge kid, but their ears are awful. They present with terrible malformations, usually cochlear vestibular nerve anomalies, and almost always bad otitis media, where the ear is just filled with granulation tissue and you can't see a thing. So in those situations, I have done the canal wall down, closed off the meatus, and then come back 3 to 6 months later when the active otitis is resolved. Because usually when you close off the ear canal, there is no more otitis media. And that then when you come back, it's not as actively inflamed and more of your landmarks are visible.
Okay.
Well,
You know, obviously,
I'm sorry.
no, go
Will
ahead.
you do diffusion sequence in the MRI after you close the ear canal?
That would be
to see
ideal.
cholesteatoma?
Unfortunately, now that you can get the MRIs done, because before you couldn't get the MRI because of the implant, but now with the magnets in place, even if you get the MRI, there's so much distortion from the actual implant that you probably can't appreciate restricted diffusion. But that would be ideal if you could just follow them with serial MRI. Most of the time, if you're going to have retained epithelium, though, it's going to be at the closure, because it is very difficult to actually completely avert all those edges. And sometimes you can get it trapped right at the opening. Thankfully, it's not usually a deeper problem.
Thank you.
So otosclerosis, definitely there are some cases of really severe, like super severe otosclerosis, where you have such bad otospongiosis that you don't have any place to put the electrode. That's not common though. And you know, more common is that you have just a lot of otospongiosis and it looks like the lumen of the cochlea is pretty opacified. I have found that despite that, you can usually get an electrode in there. And I would prefer to stick with an electrode that was a little bit stiffer, because you can imagine if you're having to fight through fibrosis to get something in there, you're going to have a really hard time getting in what we call a wet noodle. So I don't know if you've worked with a lot of what Med-El electrodes, but Med-El is, you know, it's like a floppy noodle, right? And it's, you know, some people swear that they have no problem getting that in with a, you know, with a fibrotic cochlea. I find that hard to believe. And I prefer not to spend a lot of time with a claw shoving it in, because that just kind of, you know, you could destroy the electrode that way. So coclear probably has the stiffest array. That one is the CI 512 or the 612. And that is the old one with the stylet that's pretty big, pretty hardy, was on the market for many, many years. We've gone away from it with more hearing preservation protocols, but it's really wonderful for revision cases, for otosclerosis, and for meningitis cases. The nice thing about this array is that it also has a depth gauge, meaning that it has a fake electrode that you can buy and insert first to make sure that you can get it in so you don't waste the $40,000 implant. Cochlear, unfortunately, is the only one. The Cochlear Corporation is the only company that offers a depth gauge. Depth gauges are not available with Med-El, and they're not available with advanced bionics. So unfortunately, you won't know if you get the electrode in those companies unless you put the real electrode in. There are some cases where you have to drill out the basal turn. So you don't have a round window, for example, it's completely ossified. You drill the cochleostomy and you're still in solid bone. And so sometimes you'd have to kind of just paint with your drill along the basal turn to find if you can see any lumen at all to put the electrode in. Some people have actually gone so far as to do a middle turn insertion, although we know the performance in those cases is not as good because you end up not getting any of the high frequencies that are necessary in the basal turn. Revisions, again, for every revision, I like to have a depth gauge and a cochlear CI, you know, 512 or 612 as a backup, even if the family or the parent or the patients want to do Med-El or AB, because again, you never really know what you're going to be able to get in there, because not every revision is very straightforward. The other thing about revision implants is that what you do is you successively take it out. So you start out with the internal receiver, you transect the electrode, take out the receiver, and then you progressively cut the electrode until you get to the facial recess. And sometimes you actually have to re-drill the mastoid, particularly in children, because they reossify over everything. And in that case, you don't want to have that electrode get caught on your drill and then it flies across the room, because you may have a very narrow window of time from the time that you take out the old electrode and put in the new one. And so ideally, you put the new one in the pocket, leave the old electrode in place, and very quickly with one hand remove and the other one hand slide in. So you don't have as much time for that cochlear lumen to collapse, which happens very quickly, which is why for every revision case that you have to remove one for infection, you always leave the electrode in there. The pediatric CI. So a lot of the data that we're using to justify current decision making and why we do simultaneous bilateral and why we advocate for early implantation really comes from the nearly 2 decades worth of work done by multiple centers under the guidance of John Naparko, my former mentor and boss, who really led the lead from Johns Hopkins with the childhood development after cochlear implantation study, the CDACI. It was a longitudinal multi-center study where they followed normal hearing children and compared them to children that received one cochlear implant and followed their language development over time. And they were able to show that it was multiple factors that led to outcomes, one of which being time of implantation. So the earlier you go, the better the outcome, and the closer the cochlear implant children could approximate their normal hearing peers. Other factors that showed to be really quite striking were the psychological and social factors. So if you compare normal hearing children from a low socioeconomic status with a linguistic capacity of the mother, particularly the mother that was low, this is a normal hearing child, and compare them to a child who received a cochlear implant, who came from a well-resourced family with a linguistically savvy and educated family, that normal hearing child had worse language than the child with the cochlear implant that came from the better family. Better meaning better resource, mother was more educated. So it really highlighted how really where you come from, how much money your parents have, what resources they have, makes a huge difference on language outcome. And it's not just whether you get the cochlear implant in there, and then it really does take a multidisciplinary effort that I wish that we could get all of our nation's governments to kind of pour more resources into childhood development that's not just about surgery. But at any rate, that's a different topic. But I wanted to bring that up because it really highlights how an approach to pediatric hearing loss, and really even adults, has to be multidisciplinary. The big thing that it also showed is that it's cost effective, that we should be paying for this, because children that grow up to have deafness, that end up not having oral language or being mainstreamed into society, that cannot integrate into our economy, that cannot integrate into our educational system. Their average educational level is lower. They often end up dependent on social services or what we call welfare. They don't have as many access to educational opportunities, and it is more expensive for society to not have those options open to those patients. And so I think that was very, very important in enabling us as a society to actually forcing our insurance coverage, our insurance payers, as well as Medicare and Medi-Cal, which are our government forms of insurance, to pay for this resource. Now, I did want to mention the deaf culture, because in America, we call it the big D, or el de grande, deaf, or sordo, right? Grande ese, which refers to really a very active and vibrant deaf community, right? Where their language is very much their sign language, and they don't feel that they need to speak or have spoken language. And they have a way of communicating, a way of understanding each other. They don't see the need to learn how to hear and speak orally. And I've always said with any patient that I see, if you have sign language as your dominant language, and maybe, yes, you want some hearing aids for your child so they have sound awareness so they don't get hit by a truck, right? But if you're providing your child language, great, but you have to provide them language. The reality is that most children born with hearing loss and deafness are born to normal hearing families that don't know how to sign language. They don't know how to, it's a completely different language. It is sort of like learning Russian if all you speak is English. But it is important because there is still a lot of animosity, a lot of suspicion about cochlear implant being a bit of a genocide for that community, and that it is associated with a lot of pain. It's associated with a lot of intensive rehab, such as speech therapy, which we all know is very, very important in a child's early life, but they have a cochlear implant. And it is something we need to think about, because the reality is that children born with hearing loss to hearing families live in a little bit of a crossover world, right? They aren't part of the deaf community, but they aren't totally part of the hearing world. Even with cochlear implants, they're not quite like everybody else. Even if they're mainstream in school, the stigma associated with having this apparatus on your head, you can imagine lots of middle school children, school-age children, even high schoolers are not the kindest about having that kind of a difference. And so I think the psychology and the issues with anxiety and depression that this population deals with are extremely high. Children with hearing loss have a much higher rate of depression and anxiety. And we need to address that, because it has a lot to do with just being socialized in intolerant environments, right? Which is everywhere. So these are important things for us to notice and care about as providers, even if we're just the surgeon, right? So for example, these are some examples of some of the information, the cartoons. Here you have on the left, before and after, you had a happy deaf child, normal ASL using member of the deaf community. And afterwards, you have an unhappy child that was forced into years of intensive speech therapy, trying to fit in a hearing world with no chance of being normal and scarred for life. And I think that's important for us to highlight, because a lot of the parents in this world, and some parents that are normal hearing, feel, well, I'm making this decision for my child. Should I not be able to let my child make that choice? And unfortunately, the window for spoken language development is quite early. So if you don't get implanted by a certain age, spoken language is not an option. You all know that, but I think we need to be sensitive to some of these ideas around us. Preoperative evaluation for peds, it's comprehensive like we discussed. So you have to consider the surgical and medical issues we discussed before. Imaging has a huge role, and we'll go over that as well. Obviously, the audiological assessments, their speech and language development thus far, their overall developmental status, if they're significantly delayed for multiple reasons, if they have multiple medical comorbidities, if they have a syndrome, if the overall developmental status is poor, you may want to consider that. Now, we don't use that as a reason to exclude somebody, because using a child like that and then depriving them more of some sensory input just further delays them. But it is something we need to consider in terms of expectation management. We discussed the psychosocial considerations of the family, the educational resources as well. And then the vestibular is not as common, but a lot of people will then use vestibular testing either pre and post, particularly in children that have syndromes like Usher's. Our current criteria in the US for the FDA has now gone down to 9 months. In current practice, if we can do it at 5 months, we will. But usually it takes a little bit of a huge shift of medical resources to make that happen. The criteria are prelingual profound. And if it's prelingual, severe to profound, I think, are the more modern criteria. In children that are postlingual, then the criteria go up to more moderate profound losses. They also have to demonstrate that over 3 months of using properly fit hearing aids, that they're not making significant gains. You obviously have to have a cochlea. And you have to, the normal cochlear nerve, I'm a little controversial on. We'll get back to that later, but I would argue you don't have to have a normal cochlear nerve, because we have many cases of children that don't even have cochlear nerves, but they have some sort of auditory fiber that's transmitting information, and those CIs are absolutely making a difference in that child's life. So these are the not updated, but yeah, 12 to 24 months. After 2 years, you could be severe to profound. But again, now we have come down to 9 months. Yeah, I did update it. So for adults, the audiological assessment's very different, because all of these people have already learned how to speak in most cases. If you have a completely nonverbal, deafened since child adult, and you want to do a cochlear implant, I would caution you to maybe consider something else. Because if you have a brain that has never heard, and they've never worn hearing aids or had any auditory awareness, and they have a dead ear on both sides, a cochlear implant is not likely to do much for them. And I'm not even sure that it would give them meaningful sound awareness, but that's the rare case. So adults will have an unaided evaluation, which is just like your standard hearing test. Then they will have the best aided condition. So if that means they show up with your appointment with bad hearing aids, the audiologist should have really good hearing aids that then they put on the patient and then test them with those. And they test their speech understanding in sentences and noise as well, which obviously, if you introduce noise, like the world has a lot of it, you can expect that their performance will go down. The Medicare criteria, and Medicare in the US is the healthcare for people that are 65 and older or have chronic disabilities. And Medi-Cal kind of follows those. You have to have less than 40% in the best aided condition. Hybrid criteria are more liberal, and those are approved by Medicare. Now, private payer insurance does not require it to be that low. It actually can be much more liberal in the more 50 to 60% range. Obviously, the pre-op evaluation will require a medical evaluation to make sure there's no contraindication to proceeding with surgery, and then obviously imaging. This was the traditional criteria for an adult, meaning you basically had to not hear a thing. You needed to be almost completely deaf. Now, we've updated the criteria to be moderate to profound. And definitely, this is the more modern criteria. So this is Cochlear's information for the hybrid criteria. I think the actual true hybrid candidates are rare for a couple reasons. One, how do you know that your patient's going to retain their low frequency hearing over time? Second, how often is it that you find someone that's this normal here and this bad here and still qualifies for a cochlear implant? And again, that their hearing remains stable. Most people now, we hope to catch them in this moderate to profound range before they become severe to profound or profound. Because we do know that the earlier we intervene, the better the long-term outcomes. The longer we wait, the more difficult the performance becomes in adults. So this is an example of a candidate who has moderate to profound, no responses in the higher frequencies. You can see their word scores are poor, and this is their aided condition. And they're clearly a candidate, like 840%. This is the same thing kind of in a graphical format. Here's another example of someone who has moderate to profound, speech scores in the 24%. So about 10 years ago, this may not have been considered a candidate in the US. We definitely have advanced the criteria here. Let's talk a little bit about hybrid hearing. So hybrid hearing is when you retain your natural hearing, which traditionally we've always talked to patients as being, just expect to lose it, right? Because obviously you're having this implant go into your cochlea, the likelihood that you preserve your hearing is pretty low. In the last 10 years, we've made significant strides in trying to preserve that hearing. The first generation of these temps were using shorter electrodes, where you don't expect to get to the middle and apical turns with that electrode, to leave that part of the cochlea alone. And then the thought being that you would use an acoustic amplifier like a hearing aid that coordinates with the electric amplification or stimulation of the cochlear implant. And you can use the processor in that manner if you preserve your hearing. Both Advanced Bionics and Cochlear have this capacity. I'm not sure if Advanced Bionics have cleared clinical trials. The Cochlear hybrid has been around for a while. MED-EL also has electroacoustic hearing, but it's not available in the US. The dirty little secret is that you don't need a hybrid electrode to benefit from that technology. So with the finer electrodes that are now available, you can actually preserve hearing with a full electrode array and minimal trauma to the insertion, maybe using perioperative steroids, and you can preserve your natural hearing with a traditional array, and then also use this processor. So you don't have to commit to a hybrid electrode. You can still get a full insertion and cover the cochlea for the case that the patient loses their natural hearing, so they have something in the future. The other thing that I've seen in some of my adult patients is that the quality of their native hearing was so poor, they actually preferred just to use a cochlear implant rather than the combined approach, which I thought was interesting. So every patient's a little bit different. So these are the scores that are used for electroacoustic hearing and hybrid. So obviously you need to have really almost near normal in the low frequencies. And you can actually have up to 80% on the contralateral ear, which is incredibly liberal based on prior criteria. But in the implanted ear, the aided word score needs to be 10 to 60%. So this is much more liberal than we had prior. We think that having the advantages of this is that you can perhaps discriminate music and pitch better, that song recognition and overall quality of life is better. I think we need to see with more time and more data whether that actually is true, but I think all of us know that musical appreciation in the cochlear implant population that's adult is incredibly variable. Children, prelingually implanted with cochlear implants, sometimes with just one. There are several cases of those patients going on to be music majors. Now, are they completely like all the other kids in the class? Probably not, but they can still have quite an appreciation for music that most adults wouldn't have because it's postlingual. I'm going to skip over this one. Now, there's a really lovely review article, a meta-analysis in ONN that was published, wow, now almost 7 years ago, but it really nicely goes through all of the studies that have dealt with hearing preservation. And it's gone through like all the factors that people thought might affect whether you preserve hearing. Do you do a slow insertion? Do you use steroids? Do you put steroids in the middle ear? And all these things, right? And this is what they came up with. So you can see that the data are all over the map, right? Incredibly variable, right? And I think part of that has to do with the fact that you have different surgeons across different institutions and really quite variable patient presentations, right? There's a lot of controversy, cochleostomy versus round window. One paper will say one paper will say the other. I don't really think it makes a difference personally. slow electrode insertion was definitely associated. So people now say at least 5 seconds per electrode. So I'll sit there literally and I'll just count 1, 2, 3, 4, 5. And it's painful, but maybe it makes a difference. That said, I've had patients who preserved hearing with no slow insertion where I wasn't expecting or trying. And I've had patients where I really tried hard. It was a younger patient, put them on steroids, and they didn't preserve their hearing. And I think I do my surgery basically the same way every single time. So I really don't know. But they definitely found that using steroids after the surgery was associated with positive outcome. Not associated was the difference in electrodes or longer arrays, or putting steroids inside the ear, or using the lubricant. So some people use, I forget what it's called, but it's like Helion, I think, to somehow aid the insertion. Not associated. The other problem with the data is that it's very variable in how you define preserved, right? So how you define it is not reported uniformly in the literature. And then the problem of also progressive hearing loss later. So if you talk to Bruce Gantz from Iowa, he'll say if you preserve your hearing in the first 12 months after hybrid surgery or hearing preservation surgery, then you preserved it. But again, the issue is then how much of the progressive hearing loss that you see after that is independent of the electrode, and how much of it has to do with the fact that you have an electrode there. Single-sided deafness. This is a huge problem, particularly in those patients that have sudden hearing loss. The sudden loss of hearing is incredibly devastating to most patients, as you all know. They're often very bothered by the tinnitus. They're very bothered by the hearing and noise, which is very difficult. The head shadow effect is also difficult, of having to constantly turn your head. And you know, the devices that are typically available for this, such as the osteo-integrated systems or the cross hearing aids, they don't really solve the problems of hearing and noise and sound localization or tinnitus. Tinnitus is usually one of the biggest problems that these patients have. So it is now an approved indication in the US. It's been one in Europe forever, where it's considered a medically necessary treatment for single-sided deafness there. And we do know that it is significantly better than any other system at tinnitus management. So upwards of 90% of tinnitus control, which is the highest number that I've ever seen out of any tinnitus study. Usually you get barely above placebo in most trials. And also you saw improvement in sound localization, and speech and comprehension did improve. Now, expectation management is absolutely key in this population, because they need to know it's not normal hearing. It is not normal in any way, and in some ways can be very distracting from their normal side. And it takes a lot of reassurance and encouragement and kind of constantly making sure their expectations are in line. Also, there's quite a bit of variability in the subjective experience. Let's talk about imaging. So CT and MRI are really considered the mainstay. I've actually come to the point where I get a CT and an MRI on everybody. And the reason for that is that while MRI can, you know, for adults, for example, let's just talk about adults for a second. An MRI will make sure you don't have any intracranial masses. It makes sure that you have proper fluid signal in the cochlea. It can give you good architecture. But we know that the architecture, the bony architecture, is much better seen with CT. And you can have a quote normal MRI, but the CT will help you to predict whether your sigmoid sinus is really anterior, if your mastoid is contracted. It can present you with some surgical challenges that you might want to know before you get there. I think the MRI is also important because also it gives a good baseline if the patient's ever had an MRI and you want to make sure there isn't some other cause for the asymmetry. For children, it's absolutely essential because you need to very well define the cochlear architecture, because the likelihood that a child born with that kind of hearing loss requiring a cochlear implant has an abnormality is about 30%. So 30% of deaf children or hearing impaired children will have some kind of malformation of the inner ear. It also lets you see where your facial nerve is, which the MRI can't show you. It gives you really beautiful bone tissue and bone air interface, and it's fast, and you often don't need sedation. With MRI, the real reason to get it for children is to make sure you look at the nerves. Because in rare cases, but it happens, you can have a totally normal CT scan and you may not have a cochlear nerve at all. And you would really want to know that before you put a cochlear implant. Again, I wouldn't use it as a reason to not do it, but you have to manage the parents' expectations, because if there's an abnormal nerve, I'm not going to call it absent, but if there's an abnormal nerve, it will definitely impact their performance, and they need to have that appropriate expectation. So we've actually written a paper where we found that if you look at, we reviewed the images from 18 different centers on children that have cochlear malformations and so-called absent cochlear nerves. And we found that there was huge variety on how people get these studies because they're mostly done at centers where they don't see a lot of this. So upwards of, I think, almost a quarter of patients receive gadolinium. There is really no reason for a child who's getting a scan for hearing loss needs gadolinium. The likelihood that they have tumors that are causing the hearing loss is very low. And you can still see space occupying lesions with gadolinium, but you can characterize them better with the GAD. So you really don't need the gadolinium. And plus there might be some increased risk associated with receiving it. It also, the time spent under anesthesia, right? Because if you get gadolinium, you have to repeat the study. So that's another 45 minutes under the scanner time, which is 45 minutes of anesthesia time for the child. The other problem we had is that sometimes the quality was so poor that you couldn't see what you needed to see. And the concordance rate with what the official reports said and what we saw was sometimes as low as 25%, meaning we saw something that they didn't see, or they called something a Michel aplasia, meaning no cochlea, no labyrinth, nothing. And it was actually a cochlear, common cavity. It was so clear that they had a common cavity. It was not a Michel aplasia. So the bottom line is, if you're going to be doing children that need cochlear implants and you're working with radiologists, you need to pair up with a radiologist that knows pediatric temporal bone anatomy. Furthermore, you need to look at the scan every single time because almost always something gets missed because the temporal bone is so small, but yet so nuanced with very, very detailed and minute structures. Okay, now what you really wanted to see. This is an axial CT where we have a normal depiction here on the left. Here you have a portion of the IAC. Here's the vestibule. Here are the middle and apical turns of the cochlea. There's the medialis. There's a portion of the lateral semicircular canal. The ossicles right here, whoops. And the antrum going, the adductus ad antrum going into the antrum of the mastoid. Here, you can see there's clearly something abnormal, right? So let's go through a couple of these. Here you're pointing out the semicircular canal and the vestibular aqueduct. And the vestibular aqueduct should be about the same diameter as a superior semicircular canal cut in cross section. Here you see an example where it's extremely wide. And so this is the characteristic enlarged vestibular aqueduct, which almost always is associated with this malformation. They almost always go together. Sometimes they're not, but almost always, if you only get a call for one, always look for the other because they're very common. And these are associated with a slightly increased risk of having CSF come out your cochleostomy when you do the implant. I haven't found that to be the case every time. Usually you might see a little pulse, but it's usually not a big deal. You just pack around the electrode. So here you have an example of the normal, right? Here you have a basal turn, but there isn't any differentiation of the middle and apical turns. So it's this classic like little plate with a pearl on top of it. That's incomplete partition type 2. Here you have an example of normal, and here you have a cystic cochlea. And this is the incomplete partition type 1. You can see the vestibule is also abnormal in this case. And if you scrolled up and down, you might also appreciate some vestibular anomalies. Here you have a common cavity, maybe, right? So the problem with calling it a common cavity is when you don't know if it's all vestibular or if it actually truly is a common cavity, meaning it has both vestibular and auditory differentiation. There really is no way to know that for sure anyway. There is no imaging or neurophysiological test that'll tell you, yeah, there's some vestibular fibers in there. Yeah, there's some auditory fibers. What we typically do is we look at the path of the IAC, and there actually was a nice paper recently that we reviewed, I can't remember who did it, where they did the same thing, where they basically called it a common cavity if the common cavity spanned posterior and anterior to the internal auditory canal. If all the differentiation, albeit however abnormal, was all posterior to the IAC, and particularly where the facial nerve comes off with the geniculate, then we would call that actually no cochlear component. Is that cochlear agenesis? And that's what we would argue. If there's nothing anterior to the IAC or anterior to the geniculate, then it's actually all vestibular. And the likelihood of having some cochlear information there, we don't know. That's where you would use the hearing test and maybe the AVR to say, well, if they have some hearing there, right, then yeah, maybe you should still consider implanting it. Here we have an example of a normal vestibule and a small lateral canal. Here we have an example Ah, how did that happen? Uh-oh. There we go. Okay, sorry. Here we have an example of, here's a vestibule, which is a little bit enlarged. But look at this tiny little bud. Tiny little bud. That's all he had for cochlea. You would probably be lucky to get maybe 2, 3 electrodes in there.
We don't see the presentation.
Oh, you don't? Okay,
No.
hold on. Let's see, share screen. I'll go back. Somehow, is that better?
Yes.
Okay, I hit a button and I don't know what happened. So here is the normal, but here's a vestibule. You can see this is the only cochlea they have on this side. It doesn't get any bigger than this. It's just a tiny little hypoplastic bud. That would be a challenge to get more than 2 to 3 electrodes in. Here we have normal, and this is cochlear agenesis, labyrinthine aplasia, or Michel aplasia. There's nothing there. They have a mastoid and they have some ossicles, but they don't have anything from the otic capsule that's derived. Here we have an example of a cochlear aperture that's normal. We consider the cochlear aperture if it's around 2 millimeters. If it's under 2 or absent, so you can see it's completely ossified and bony here, you can appreciate there's maybe some enlargement of the vestibule as well. This is a very subtle finding that if you're not looking for, most people will blow over and not even notice. But this is really important because if you see this, almost always you have an aberration of the cochlear vestibular nerve. And so here's an example of the internal auditory canal, which we considered normal if it's somewhere between 3 and 5 millimeters. If it's really big, we tend not to get excited. That usually doesn't mean much. If it's really super teeny tiny, then it's usually a problem, right? Because you probably think, well, that's probably not a normal nerve that's in there. We'll talk a little bit about cochlear implant electrode selection now, where this is the advanced bionics that we have available here in the US. These are the newer versions where it's a slimmer profile. The 90K Advantage is the one that still has that very thick coin on the bottom that makes it stick out a little bit. That's what all of the cochlear implants used to look like. They have a Slim J, which is meant to be a kind of a straight lateral wall electrode. They have the mid scala, which is meant to be not perimedular, but mid scala. And then they have this IJ. Personally, I've never used this one. I'm not sure what the advantage of this one is. Then cochlear, this is the CI 512/612, which is the one that has the stylet that you advance off the stylet that's got the bigger profile, but it's stiffer. This is the new 632/532, which has the sheath. So it straightens out the electrode on a sheath, but then you remove the sheath and you have this very slim perimedular cochlear array. This is the fully banded array. This is my workhorse for all of the common cavities or cystic cochlea, where we think that the neuroepithelium is actually not in the center like it normally is, but more in the lateral walls of that cystic compartment. The CI 512 or 622 is a straight array with no stylet. It's meant to be a lateral wall electrode. We've already talked about the criteria. Medel has a number of arrays that differ in how long they are. And they actually have the longest array up to 30 millimeters. Whether that confers an advantage, I'm not really sure. They also form these ones that have these little plugs that are meant to seal the cochleostomy. I don't find this to be terribly useful, quite honestly, because it's a fixed diameter, right? And it's meant to fit perfectly in a nice little circular hole. You don't always have a perfect circular hole when you're making a cochleostomy. So the fit is never going to be uniform with that little rubber stopper. I find it much more useful, and this is for a concern for CSF leak, right? A gusher. I find it easier to make a bigger cochleostomy, just use a regular array and pack very tightly around it with soft tissue. And that usually is much more effective at stopping the egress of CSF. This is just showing us the difference about where these electrodes sit, lateral versus perimedular. And my very informal feedback from a lot of audiologists is that they don't really like these lateral wall electrodes because the predictability of how close that is to the neural fibers is much more variable because it's not as close to the medialis. So the performance can be a little bit more unpredictable. So we talked about which array for which electrode. So this is the common cavity, right, as illustrated here. But most people have hypothesized that the neuroepithelium is somewhere around the periphery. The reality is we don't really know, right? We don't have electron micrographs of live patients to see where the neuroepithelium is. So you're better off using an array that actually has the electrode context circumferentially around it, right? Because most arrays will have the electrode contacts only on one aspect of them, right? So all of these electrodes are really facing the medialis, right? If your neuroepithelium is all around you, you really want the electrode contacts to be circumferential. And so I will use the straight fully banded array from Coclear for everyone that has a cystic cochlea and common cavity. For the Mondini, any electrode works fine. You should just treat that like a normal cochlea from an electrode standpoint. So in terms of what electrode for what problem depends on the presence of a malformation. We talked about ossification using more the stiffer arrays, degree of residual hearing. So if you probably don't want to use the 512, 612 if you're trying to preserve hearing because it's such a big bulky electrode. Progression of hearing loss. So again, if you see things that are progressive, maybe don't consider the hybrid. Lateral wall versus perimedialar. I really defer to my audiology colleagues on this one. I think that they're not used to arguing with surgeons about what electrode to use because they really defer to us. I actually think much more collaboratively with my audiologists and really rely on them quite a bit. And if they have this history of this lateral wall really being difficult to program, I really rely on that. And I don't think that surgically it's that much more difficult or easy to use one electrode array over another. That said, there are many surgeons out there that only use one company and one electrode because that's what they know and that's what they're comfortable with. I would caution you not to do that because I think you really should dictate your electrode selection based on that patient's individual makeup, their anatomy, and also your audiology preferences, because you should be comfortable with all three companies or whatever companies that are available to you so you can meet the needs of all your patients. I did want to spend a little bit of time talking about nerve anomalies. So the way that we detect the presence of an abnormal or normal cochlear vestibular nerve based on our current imaging technology, which is not where it needs to be, is we get an MRI that has a high resolution, heavily T2 weighted axial and then sagittal and coronal obliques through the perpendicular through the plane of the IAC. So you can see the nerves in cross section. And normal is when you do that, you get this beautiful view of the IAC and the fluid lights up bright because you would expect that. And the nerve bundles are little black dots. So this is the facial, that's the auditory nerve. And these are the superior and inferior vestibular nerves before they've branched into their separate segments. So you should see 1, 2, 3, 4. Normal is when you see 2 nerves in the cistern because you see nerves 7 and 8 as they exit the brainstem or go into the brainstem. And then the 4 nerves should be seen in the most lateral aspect of the IAC. So you can see here, got a nice normal view. This guy is just a loop of ICA. The clinical significance of these vascular loops is highly controversial. I don't think they mean anything, but some people like to think that if you decompress them, you don't have tinnitus or dizziness. I don't ever recommend you do that surgery. I just don't think it's worth it. But then you can see here, this is very abnormal compared to here. There's so little fluid signal, you can barely even see if there's an internal auditory canal. And so when you do these, when you do these in cross section, here's an example of where you only see 1 nerve. And here you see 3 nerves. And it looks like there's just an absent cochlear nerve, right? Here are other examples where you have normal and then so abnormal you can't even see what's in there because it's so tight. But the question is, you don't really know what's in there. And historically, these patients were just said, oh, you have no hearing nerve, you can't have a cochlear implant. But then when you actually tested them, they actually had some hearing. And which is shocking, right? How could they hear with a hearing aid if they don't have a hearing nerve? So several progressive centers said, okay, let's put a cochlear implant in. And lo and behold, they did really well. I mean, better than you would expect. There are the unicorns, right, that are reported as actually having spoken language and being mainstreamed. They're rare, but we do see a tendency that and we'll get there in a second. Sorry, I'm getting ahead of myself. So the traditional dogma has been, there's a cochlea and there's a nerve, do a cochlear implant. If there's absolutely no cochlea, well, of course, you can't really get a cochlear implant. Go for an ABI. And that's still controversial, being worked out internationally. What do you do with these kids that have these abnormal nerves? And again, I don't call them absent anymore because there's clearly some auditory fibers going on in some of these kids. So we looked at our data. We already talked about this. So I classify these nerve anomalies according to Catherine Berman from Australia. And we both she came to it and published it at the same time that we were doing the same thing with our neuroradiologists. And you basically describe what you see. 0, meaning it is so narrow you can't see what's in there. 1 is you have enough to see, but there's only one nerve, which may be the facial, right? 2, 3, 4 is when you have a distinct something there that looks cochlear, but it's really small. And then you have the normal complement, which would be normal or 5. And when you stratify these patients in terms of their hearing outcomes and their Berman class, we do see a trend. Now, mind you, look at these numbers. They're very small. So this is out of the 40 kids that we have, 20 of which that receive cochlear implants. So again, the percentages have to be weighed with a grain of salt, with a little bit of caution, because these are small numbers. But according to Berman's data and ours, you do see a trend to having benefit, meaning you can hear and have sound awareness, some of whom go on to having spoken language, either open set or closed set. And the higher the number, meaning the more nerves you have there, the better. So 3 and 4 do much more robustly, but I can tell you that Dr. Hewitt and I, who I think is on the call, we share several of these abnormal patients together, and she's actually been following them for several more years than I was able to. And several of them actually have spoken language. Now, is it normal? Do they still need help? Absolutely. But having sound awareness and some ability to communicate with a family that does not sign natively is a huge help for families. Let's see, we've kind of already gone over this. I'll skip over the genetics. We have a genetic study that's ongoing where we've actually been able to identify a number of novel genes that are implicated in the absent nerve. So bottom line, when do you not do an implant? There's no cochlea, that's obvious. Facial nerve blocking access to the cochlea. I would not use a CT scan to determine this, because what you see intraoperatively can be very subtly different, but make a huge difference. So for example, I had a patient who had an abnormal ear. She had an incomplete partition type 1. She had a normal course of her main nerve, but then she had these 2 tiny nerve fibers crossing her promontory that were not Jacobson's nerve. I stimulated them at very low level, and it stimulated the facial. That made me a little nervous, but I just made sure to make my cochleostomy in between those 2 nerve fibers. And she woke up fine. So again, there are other scans where the nerve looks really anterior and the canal is super tight and you don't think you can do it. You don't really know until you get in there. And as long as you're familiar with what the nerve looks like through bone and how to find it, you should be able to find it and not injure it. Cochlea completely ossified. Again, you really don't know until you get in there. So don't give up until you try. The traditional dogma is if you can get at least 8 electrodes in, ideally 10 or plus, then you should still have some benefit in getting the implant. The other reason is when the patient doesn't want one, very clear. If the patient or family has unrealistic expectations, so for example, they just want to get implanted and be normal in here, no rehab. This includes adults. All of my adult patients understand very clearly that they have to spend a couple hours a day practicing their ear without the other hearing aid and repeating back word lists or phrases. And the patients that do this will obviously do better than the ones that just sit there and watch television. Absolutely. So I tell my adult patients kind of a miniature version of what the families hear from their children for speech therapy. We've talked about the delusional psychiatric patients. Radiation can be a kind of a plus minus. Okay, so there's my little one. That's her getting her hearing test when she was just born. And that's her now. She never stops talking. Sorry, I've gone a little bit over, but I'm happy to answer any questions if anyone has any specific concerns or comments.
Muchísimas gracias, la plática estuvo increíble. La verdad es que me di la tarea de estar revisando tanto los artículos como, lo voy a decir en español, ¿está bien?
Sí, sí, no, está bien.
Ajá, como su currículum, y la verdad es que también detecto también tanto profesionalmente mucha ciencia como también mucho ser humanitaria. Veo que tiene varios premios humanitarios. Entonces, noto que en el trabajo, es que en el fondo el trabajo tiene toda esa sensación de ayudar a los niños, y noto la frustración que hay de repente en los artículos cuando usted quiere ayudar a los niños que tienen pocos nervios en el conducto auditivo interno, pero que a pesar de eso pueden mejorar su audición siendo implantados con implante coclear. noto esas ganas justo de encontrar esa clasificación que ya comentó de Bierman, que pueda predecir precisamente que estos niños puedan escuchar. Y de hecho, justo hoy un doctor de España me decía, aunque haya pocos nervios, justo lo que usted dice ahorita, aunque haya pocos nervios, puede ser que a través del facial, bueno, eso lo comentaba él, vengan fibras cocleares y esas sean suficientes para que el niño pueda tener respuesta al implante coclear más que a un implante, más que pensar en un implante de tallo, pues.
Sí.
Entonces,
So I'm just gonna, voy a hablar algo para John, porque creo que ella todavía está. John, are you still here? Let me see where you went.
Acabo de aceptar a...
I am here.
Ah, there she is. Okay. So Erica was just saying about how, you know, the controversy regarding the children with absent or abnormal nerves, and also a colleague of hers from Spain, España, no? Where the theory is that there must be some sort of auditory fibers that are traveling along whatever those nerve bundles are. And that, yes, we can have benefit. And Joan, I wish you would comment a little bit, because you have so much experience with seeing those patients long term, really how it does make a difference in their lives.
Absolutely. So we've seen it make a tremendous difference for these children, and for the families, because it keeps their children so much more connected to them, that there is oral speech and language. The first thing I would say is, from what we've seen, and obviously I'm not reading the radiology reports, but it doesn't seem that there is necessarily a correlation to the radiological results and which ear does better. That actually implanting both ears is the best. That gives them the most information. Because we've seen some children where the first ear was implanted that seemed to be the better ear, and then they later got the second one, and they actually did better with the second one than they did with the first one. But having those two ears together seems to be the best for these children, having extra information. And we have seen that almost all of the children have receptive language through their implants. You can talk to them and they understand. Their expressive language may be oral language. It may be a combination of oral language and sign language. They may respond in sign language, but they can understand quite a bit with their implants.
How many patients do you have that have cochlear deficiencies or cochlear vestibular malformations and have good responses with cochlear implant?
Almost all of them.
Almost all of them.
Actually. Yeah.
We only have one. I mean, I've been thinking we only have one who has not done well. And that patient also had multiple implant failures with recalled devices. And I think that really hurt his progress. But he's the only one that I can think of who, who does not do well. And they love their implants.
That's good to hear, because we generally think they have no cochlear nerve, or is very hypoplastic or not sufficient nerves, then we won't do a cochlear implant. But maybe all this time we might be wrong.
Well, and like Dr. Kari said, it's really interesting that we get audiological results on these children even before they're implanted. Many of them have responses. It may be at 100 decibels or 110 or 120, but many of them have some types of responses, even unaided.
Thank you. I will leave Monica, Doctora Monica and Dr. Garcia Lara to continue with the questions and comments.
So I have a question for Elina. So they're asking me if you could expand more regarding ventilation tubes and CIs. Whether you wait for the ventilation tube to full and then you put the cochlear implant, or you put it, or you really don't care, or.
No, actually, some people will put them in, maybe space them out by a month. So do the myringotomy tube and then do the cochlear implant. I've actually done them at the same time sometimes, because my feeling is if it's not pus, it's just fluid, that's fine. That might get me labeled as a rogue and kind of dangerous, but I've never had a problem doing that. But no, you don't have to wait for them to fall out.
Okay.
Doctora Celara, ¿alguna pregunta? No sé si en el Zoom hay alguna pregunta.
Yes, first of all, Elina, thanks a lot for your lecture. It was so clear and interesting. And we have some questions on the chat. I would like to start with this one. Somebody says, what has to be the size of the cochlear nerve, at least the size, to decide to put a cochlear implant or to decide to perform the brainstem implant?
So most, aside from Italy, most people would argue you do the cochlear nerve first. I mean, the cochlear implant first. And that's whether you have a Berman 0 or 4. Definitely, if you have a Berman 4, that argues much more for a cochlear implant. But because of the variability of how the hearing status changes independent of the imaging, because the imaging really does not correlate to hearing at all. And it doesn't correlate as to whether you're going to benefit from the CI at all either way. So most people would advocate doing a cochlear implant and then an ABI if the CI doesn't give you at least pattern. So if you get pattern recognition and sound awareness with the cochlear implant, you are not a candidate for an ABI because you may not get much better than that with an ABI. And so in some places like Turkey, what they're doing is with a lately, the late identified, let's say a 3-year-old, rather than making them wait the full year or two to see if the cochlear implant actually does anything, he would do an ABI on one side and a cochlear implant on the other. I'm assuming based on the fact that they're both the same, which sometimes isn't the case. Sometimes both ears are different. So there aren't really any rules at this point. There are very poor guidelines. Right now, the ABI in the US is really only being used in clinical trials. But there's a lot of controversy. We really don't know, when to proceed in what manner.
So the size is not the main
no.
thing. Okay,
no.
I have here another question. How the surgeon can test the function of the cochlear nerve to choose the auditory prosthesis?
You can't. So, some people do promontory stimulation. Some people see if they can get electrically evoked ABRs. The reality is there's no test that tells you whether this cochlear implant will work well. There really isn't.
Sure.
I have another question. So when you identify an enlarged vestibular aqueduct in a child bilateral, do you give that family some recommendations regarding sports or life, or you just leave them?
Yeah, good question. Because you're right, that condition is associated with stepwise declines with mild head trauma. We also see stepwise declines without head trauma. And you counsel the family that it's largely anecdotal. We don't have great evidence that we see stepwise declines no matter what. And my feeling is that these children are already dealing with so many issues that differentiate them as different from their peers, that to further socially isolate them from these activities that they might otherwise enjoy, like soccer, like football, what have you. I mean, I'm sure you understand with football in Mexico, right? Trying to tell a young boy not to play football. I mean, are you kidding me? So you kind of have to wait, but let the family choose, knowing that that is a possibility.
Thank you, Elina. Kari, can you explain more about what a traumatic technique for cochlear implantation do you use? Or what are the steps you usually choose?
Well, let's see. I think everything in otology is pretty much atraumatic. I do an extended round window usually because it's easier. It's very easy to identify the round window. And so you do minimal amount of drilling, only enough to make the opening that you need. And then you just a very gentle, slow insertion where you just count meticulously 5 seconds per electrode.
Okay. That's interesting. So it's slow insertion.
Slow insertion. But however, there is somebody, Marlon Hansen, he's an MD, PhD at Iowa, also trained at House, and he's also an engineer by training. And he has developed a robot to do this mechanically steady, slow insertion, so it's not prone to human error. I think they're in clinical trials right now, and that's something that's probably going to be more widely available.
I kind of heard that in your talk that sometimes you will use very slow insertion and have poorer results, or sometimes it doesn't relate. I mean, it depends on the year, Because you will use the same technique and have different results, right?
Yeah. I mean, I preserved a hearing in an 84-year-old male, which is traditionally not thought to be in an age that you can preserve hearing. He had had a tumor that was radiated, and I did not do a slow insertion, and he preserved his hearing, which I was shocked by. So again, I think from a patient to patient, it's hard to know what really makes a difference, and which is why that meta-analysis was all over the map, because I think we don't know enough about each individual's hearing loss to really know what factors they need to preserve their hearing.
Thank you.
So another question. So would you expand, I know that's not the main topic, but could you expand, tell us about your experience with ANSD, with auditory neuropathy, and taking advantage that Joan is here, maybe she can also skip in.
I can tell you that they are a more difficult branch of children because it's hard to really know what their hearing is, because the ADR obviously is not going to help you. And they have variability, so their hearing really can change. I know that from the children that are ANSD and profound that are deemed candidates, they actually do quite well with cochlear implants. Surgically, they present no problem. They have normal anatomy. But I defer to Joan on kind of the performance and some of the things you see clinically with them.
Well, I think that we're seeing under the ANSD umbrella, two different types of patients. So I think that those who have cochlear nerve anomalies can show up on our audiological testing as ANSD patients, because they can have a normal cochlea, so we can get otoacoustic emissions, but their hearing loss is really a cochlear nerve deficiency. And then we have those where we have some type of lack of synchronous firing within the cochlea or the neural tissue. And those to me are the more typical ANSD patients. Obviously, if we're dealing with a cochlear nerve deficiency, we're going to have the same issues that we have with other patients with cochlear nerve deficiencies. But for those are abnormalities, but those patients who it really seems to be some type of asynchronous firing or something, they seem to do very, very well. They often don't need a lot of stimulation. They do very well with small amounts of stimulation. It's almost as if they just need that implant to provide the synchronous stimulation, and then they hear very, very well.
Okay, thank you.
So I'm afraid that I have some domestic responsibilities that are calling to me. I do appreciate the flexibility in moving the meeting up, but can I answer maybe one more question if there is one?
Yes, Dr. Garcia Lara, creo que hay unas
preguntas. Sure, we have one here on the chat. In a patient who has a cholesteatoma, how long do you wait for to perform the cochlear implant after take out the cholesteatoma?
So you would do, it depends. If it's a canal wall up, ideally, right? You would wait the full year, or maybe even a year and a half, and then you'd go back and make sure there's no recurrence. And if there's no recurrence, you can do the cochlear implant at that time. If it's a canal wall down, obviously it presents an interesting challenge like we discussed, but I would wait at least a full year. Obviously, if you know you're going to be doing a cochlear implant, then I would advise you not to do a canal wall down. And if it required a canal wall down, then do the subtotal petrosectomy where you close off the ear canal. But you need to wait at least a full year between the cholesteatoma removal and then putting the implant in.
Okay, so thank you, Elina. We know you have to go.
I'm so sorry, but listen, I'm more than happy to entertain other questions if people want to email, or I don't know, have a group chat some other time over Zoom or whatever. I'm always available for that.
Thank you, Elina.
All right. Thank you so much for this opportunity. Muchísimas gracias a ustedes.
Gracias, que estén todos muy bien. Buenas noches.
Buenas noches. Thank you.
A los que se quedan conectados, les avisamos pues que tenemos nuestras próximas pláticas el 17 de septiembre y el 24 de septiembre. Tenemos al doctor Felicito Santos el 17 y el 24 tenemos al doctor García, si quiere comentarnos.
Sí, el 17 de septiembre tenemos el placer de contar con el doctor Felicito Santos de Monterrey, hablando sobre terapia intratimpánica para hipoacusia súbita. Y el día 24, ambos son jueves, tenemos el gusto de un profesor internacional, el doctor Enrique Iturriaga, hablando de abordajes transcelares de base de cráneo. En ambas están invitados ambas y ya enviamos a ustedes la difusión oficial con el horario, que seguramente será en este mismo horario, pero ya la tendrán ustedes y lo podrán checar también en el canal de YouTube.
Gracias. Y les recuerdo que para los miembros del Colegio Mexicano de Otología, Neurotología y Cirugía de Base de Cráneo, estas pláticas representan puntos. Así que muchas gracias por su presencia y que tengan muy buenas noches. Gracias.
Buenas noches a todos. Gracias.